Hello, everybody, and welcome back to Conversations or Unsolicited Conversations with J and B. Jodi and Brad. I'm privileged again to have Jodi, nurse practitioner, and her esteemed colleague, Dr. Book here. We're talking about sleep. We did an episode on sleep earlier. We broke it up into two segments, and this is kind of the second part to that. So I hope you enjoy this portion of it as well. A lot of great information, and I've learned a lot about sleep, and these guys are really good at what they do. So I'm going to kick it off by asking Dr. Book a question, and we'll get right into it. The first one I want to kick off with, and here we go, is on sleep disorders. Dr. Book, could you talk about sleep disorders, kind of what they are and kind of what happens?
Well, how much time do we have?
We only have a few minutes, people.
Minutes, okay. Yeah. Well, Brad, the International Classification of Sleep Disorders recognizes about 90 named sleep disorders. So there's a lot out there. We understand that sleep is a very unique thing, and that there are very unique ways that sleep might bother us. We see there are some very common ones, however, that tend to affect more people than not, and those include things like shift work disorder, people working different shifts and having their sleep schedules rearranged all the time. Insomnia is perhaps one of the most common sleep disorders that we see in the United States. Yeah. Insomnia is defined as either having difficulty initiating sleep, so laying in bed, not being able to fall asleep, or sleeping and then waking up at some point in the middle of the night and not being able to go back to sleep. And the issue with insomnia is that in the schedules that we keep for ourselves, we might carve out 8 hours of sleep at night, for example. But if we're only getting 4 or 5 hours of sleep because we can't fall asleep or stay asleep, then we're not getting enough sleep. Yeah. And so the amount of sleep is really important. And then we see the sleep apnea disorders is a very common thing in the United States. And there are a couple different flavors of that, but essentially there are problems with breathing while we're sleeping at night. And that leads to sleep fragmentation. It leads to inefficient, poor sleep, junk sleep, just like Liev Schreiber on the commercials for the Serta mattresses or whatever they are talks about. It's junk sleep. Yeah. These are very common disorders, and they can often exist together. So it's important to understand that you may have a little bit of insomnia, you may have a little bit of sleep apnea. Those things work hand in hand, but the end result is that poor sleep results in consequences, and there's implications to that.
Can I mention one thing that just because I learned it from you guys, and actually from Matthew Walker in his book? Mm-hmm. Do you remember this, Dr. Book, how there was a study done with two groups of people, and they took a look at one control group. They got a good night's, in terms of availability of sleep, they were allowed to sleep at least 8 hours. Mm-hmm. And the other group, they kept them up all night long. Yeah. All night long, and they didn't sleep. And then they gave them some list of facts to remember the next morning and put them under an MRI and looked at brain activity. And the hippocampus, which actually is kind of the inbox for the brain, from what I understand, kind of had, for those people who did not sleep, it was kind of returned to sender. Yeah. It never was able to enter the part of the hippocampus. And what they found during the exam on questionnaire was that the people who did not sleep performed 40% worse than those that did. Now, I'm thinking about kids in sleep, and I'm thinking, my gosh, that's a difference between an A and an F.
Right.
That could have been the reasons of why, I don't have my PhD.
That's one of many. Potentially. Hey, but no, you
brought him here for honesty.
but you're exactly right. I mean, and those types of studies have been repeated over and over and over again with similar results. That lack of sleep impacts function. Physical function. Olympic athletes are told that they should perform in the afternoon because they are at their peak physical performance at that time after having had a good night's sleep. We see over and over again that performance drops off. In another study, these have been repeated, they looked at cohorts of patients who were given 8 hours of sleep compared to those who had 4 hours of sleep. And so they still were able to sleep, but only 4 hours. Right. Mm-hmm. And their performance on reflex testing was essentially similar to somebody who had an alcohol content of 0.08. So folks with no other things going on other than a lack of 4 hours of sleep, getting up in the morning, going to work, were drunk for all practical intents.
Wow. So is this what happened to Tiger Woods?
Yes, Your Honor. That's my story, and I'm sticking to it. Right? Yes.
Okay.
But there are likely more people in the United States that die of drowsy driving accidents than of drunk driving accidents. We just don't have a great roadside test for it.
Okay. Wow.
But absolutely, performance drops off.
Okay.
Yeah. So our shift workers, our paramedics, our firefighters, our, healthcare providers, it's hard to treat them. But the thing is, when you can teach them how to focus on good sleep hygiene, when they have the opportunity to sleep, and taking out those other things that may fragment their sleep a little bit more. A lot of times I remember when I did the night shift, I would want to go home and I would go directly to sleep. I got off at 6:30, maybe even 7 o'clock, and I would go straight to bed. Some people have to get off work and their spouse is already at work, so they have to take their kids to school. That really impacts then their ability to fall asleep generally, because they're doing something stimulating before they have to go to bed. So it's that sleep hygiene that shift workers really have to focus on when they have the opportunity to go to sleep, to make sure that it's good quality sleep for the time that they have, making sure, they don't have then sleep apnea. So we can't sometimes always control central sleep apnea, but obstructive sleep apnea we can. So getting in that fitness or exercise every day to maintain a normal body habitus so that they don't have that risk factor for that sleep disorder contributing to fragmented sleep when they are shift workers. And I also encourage those, if they can, to stay on the same cycle. If they work night shift, to try to do that even on their days off. It's really hard if you have a family life, but to try to do it as much as possible. We have a lot of people that do, 2 days of a day shift, then 2 days of a swing shift that's an afternoon shift, and then into night shift. Those are the ones that I find very difficult. And are we doing them a disservice? Should we be educating employers that we should not be going through the different stages of, or the different shift work cycles throughout the day, throughout the week?
Wow,
I think it's, we are, causing, if that's an employer that you have to do those different shifts, I think it's hard on a patient.
Well, it's interesting you say that, because I'm looking back and thinking about, as a business owner, I would have employees that would apply for positions, and that's in this position, it was a 7 a.m. start time, right? And they would say, 7 a.m., I'm kind of a night owl, 7 a.m. is a little early. Can I come in at 8 or 9? And I'm like, no, you need to be at 7 o'clock. But, the reality, looking back, their chronotype could have been as a night owl, and that's when they function the best, and that's when they perform the best. And the reality, as a business owner, I could have probably done a better job, in the sense that they could have done a better job and performed better in their job than forcing them to get up when they weren't ready to and come to work tired.
And I think there's a couple of points to make from that. One is, as you alluded to with the chronotype, we're going back to the circadian rhythm thing, where we're designed to be sleepy and to fall asleep at a certain time during the dark periods of the night and be awake during the light periods of the day. And for some of us, that is shifted a little bit earlier. We may be sleepier a little bit earlier and want to get up earlier. And others of us tend to be awake later in the night and then want to sleep in later. And it varies. Most of us are pretty close to the, maximum, trying to be asleep around 10 or 11 at night, but it really varies. And it's interesting. As a business person, I don't know the answer to this, but with lost productivity, what are we seeing sort of economically with that? I mean, what?
Yeah, it's pretty significant when you look at it from a national level, right? I think nationally, if I remember right, from the studies that were done just in the U.S. Now, there's been done studies in the U.K. and Australia as well, but in the U.S., we lose about now how do they do it? I don't know, but $244 billion annually, which is 2% of our GDP.
That's just about the Viagra.
That's what
that's what they make.
That's a good point.
Okay, all right.
But the point is that because how are we losing it? We're losing it because of productivity. People are not sick time. People are away from work and take more sick time. And not only that, but the diseases and the doctor appointments and all that comes up because of a lack of sleep that we have to now attend to. And look at the burden on the medical community and the costs associated with that because of sleep. So, yeah, I think we need to think about it, and just in terms of it's become a trade-off. In other words, we're a 24/7 economy. I get that. Yeah. However, are we trading off the fact that we are a 24/7 economy and all that brings about economically? But what about the $244 billion we lose because and the revenue we lose as a country because we have people with all sorts of sleep disorders and accidents and health issues and all this associated with it. I think it's a good question that we're going to have to ask ourselves in the future. What can we do for employees, especially the ones that don't have to work at night shift or don't have to be at work at 7 or 6 a.m.? What are we going to do for those folks in order to help them to be more productive and actually live better lives?
Mm-hmm. I think in an ideal world, it would be great for our shift workers. And I grew up in the healthcare world. So I've done night shift, I've done day shift, I've done swing shift, and I've switched back and forth. And it was much easier younger. I would never want to do it now. Do we create wellness places for our employees that are shift workers? Like, do we have light therapy? Because we know that bright light during the day helps keep us awake. So for our shift workers, do we make sure that the lights are a certain level at nighttime, but then during the day that they have all the accommodations for them to get a good night's sleep? You know, from a benefits perspective, if you are a night shift worker and you're looking at insurance, because you are higher risk for, and legal fees too, you're at high risk for divorce rates in those that are shift workers that work nights. You also have more chronic conditions that you're treating, the obstructive sleep apnea, the cancers from night shift workers, from those that just did that. You have all the sleep disorders from night shifts. So what are we doing for our employees to
I would think
really impact?
Jodi, this isn't a subjective matter where we just kind of think and hypothesize that this may be happening. We actually have data that proves this happens.
Right.
And I think with this podcast, I think, Brad, you and I came together. We're from two very, very different backgrounds. You're business and I'm healthcare. And,
well, you're smart and I'm not. Okay, fine. That's fine, Jodi.
No, that's not what I said, Brad. But we came together to really talk about topics like this and create awareness.
Right.
And like we want to create awareness and give you guys information, if you're listening to this, to take to your healthcare provider, because provider-patient relationships now, it's not about you go to the doctor. Like my father-in-law was like, I go to the doctor, whatever he says, I do. Mm-hmm. And I take this pill and this is what I have to do. I'm not going to make any questions about it. It is a shared decision between the provider and the patient to be educated on what we are talking about in that visit that day, and why we think as a provider, we think this should be the first approach and that approach, but also bring together the team, the rest of that patient's team. Like Dr. Burke and I, we don't even work in the same office, but I talk to him every day and bounce ideas off from a multidisciplinary standpoint to try to make sure that we are doing what is right for the patient. That's what I'm hoping that we can accomplish with this is really creating awareness. And we're not going to do it all in one episode and in one conversation with Dr. Book, but hopefully we're creating some awareness for you as an individual to take to your provider and advocate for yourself.
Where does drugs come into it? I mean, we have all sorts of supplements out there today. We spend $50 billion as a country on supplements. But does magnesium really help? Does melatonin, does that really help? And then what about prescription drugs like benzodiazepines and Ambien and all that? So how is that used in your arsenal in order to treat people with sleep disorders? Well,
I think in the big picture, I'm going to defer some of this to Jodi because she's more on the medicine side of things.
Okay.
To be fair, I'm an ENT doc and otolaryngologist. I'm a surgeon, so I treat a lot of sleep apnea with surgical interventions, and not that those things don't overlap, but I'm curious.
Jodi, it's yours.
Tell me medication-wise, or supplements, I try to obviously work on sleep as the first, medication I prescribe, and that means working on good sleep hygiene. So same sleep time every day, wake time. We already talked about this in our last episode of good sleep hygiene. And then if we're still struggling with that good sleep hygiene, because life gets in the way, you may be a shift worker, you may have an increased amount of stress in your life. You may have sick children.
I can't tell my boss when to show up and
right.
Okay.
Your work schedule changes, or you have just stress. So you're on this continuum of life, and life is getting in the way. So consistency is key with anything. So some supplements that I've found to be pretty effective, and I try to make them as natural as possible, like what our body is used to metabolizing, and We're all made of electrolytes and cells, and we're also made of hormones. So magnesium, I think, is a great supplement to help with sleep, because if we had a pretty aggressive workout that day, it kind of helps our muscles recover a little bit. It helps puts us to sleep, helps us relax a little bit. Melatonin can help kind of consolidate that sleep. It's a natural hormone to us.
Well, so I see a lot of patients who come in and they're on medications, and even there's sleep apnea patients, but they're still being treated with medications like Ambien or Seroquel or Trazodone. And my understanding is that those medications may not be always the best things. And what's your experience with those?
I think it's a Band-Aid. I mean, if somebody comes in, they go into their primary doc, they complain like, I'm not falling asleep very easily. You don't have very much time to do a full sleep questionnaire. You prescribe a medication. You want to help them at that point in time. That's what happens. Then they come to us and I'm like, oh, they're on these medicines and I'm not really sure where to start. I mean, generally we do a sleep study to identify kind of what's going on, what may be fragmenting their sleep. And I try to wean them off of drugs to see. I'm not a huge fan of Ambien. Probably I have a little bit of PTSD from that as a nurse. I gave it to a patient. And, I mean, it was the first black eye I ever had, and I was knocked out. He came out and he had some parasomnia activity because of the Ambien.
So is this parasomnia, Jodi? When I was prescribed 10 milligrams of Ambien at one point because I couldn't sleep, and I got online about 2 a.m. and I ordered 4 different pairs of shoes from Spain.
Yeah.
What's going on there?
What size are you?
Did you want them? I think we're 10 and a half.
Oh, okay. My feet are bigger than yours. Well, we might get into that a little later too.
So what was I doing?
Yeah, parasomnia activity is you are awakening and you are not ever aware of it. So,
you're doing things.
Like
so you do things, sleepwalking.
Okay.
Sleep talking is, in the parasomnia category, but you're not doing anything to harm yourself or someone else, or I guess go into debt because of your shopping activity.
Now you tell me.
There are some people that sleep eat. There's abnormal sexual behavior at night that they don't even know about.
What you do in your own bedroom is, that should be in that's your.
What happens in Vegas stays in Vegas.
They had to catch Viagra.
But do those medications actually? I mean, I'm just curious. Do those medications like the Ambien and the Trazodone, do they really help sleep?
They help people fall asleep.
Okay.
But if you then have, say, obstructive sleep apnea, you're still, you may be negatively impacting that.
So you're just throwing patients under the bus at me, say, fix their sleep apnea. I'm still going to give them Ambien.
Yeah.
Okay. All right. I just want to make sure. All right. We're on the same page.
I don't prescribe it.
That's true. Okay.
I will when I need to. I need to get a good sleep study for somebody.
Do you use benzos?
I generally don't. Benzos tend to be very addictive. They work very quickly. But if there's something underlying that I need to identify, I don't want to give them a medication before I know nothing about them.
And they can be rough on older people.
Right, definitely rough on older people. And the way they metabolize, and as we age, we just metabolize differently. So exercise is always my number 2. Besides sleep, is my number 2 recommendation for good sleep, because if you're exercising a good amount, which the U.S. Preventive Services Task Force recommends that individuals should get 150 minutes of physical activity per week, 75 minutes of moderate to aggressive activity.
Can I do that all in one day?
Yeah. Well, no.
Oh, okay. All right.
We want to do it, daily, something, 20 to 30 minutes. And we want to fatigue the mind and the muscles. And that's pretty much what Trazodone does, what melatonin does, what magnesium and Trazodone will do to help people fall asleep is the same thing that physical activity will do.
So when should somebody talk to their practitioner about sleep issues? I mean, obviously if they can't sleep, but let's say they snore, or they're getting up in the middle of the night to go pee, or they're getting up in the middle of the night because they're stressed and they're looking at the clock 3 or 4 times. At what point do you say you probably should talk to your primary care physician about sleep?
I think that we should start talking about sleep in our youth when you go to your pediatrician. And most importantly, like as adults, every time you go to your primary care, you should talk to them about sleep. And if you ever have an elevation in blood pressure, you should be talking about sleep at that point in time. If your spouse says anything about snoring, absolutely should be talking about sleep.
I think the bed partner is really important.
The bed partner is very important.
I got diagnosed with sleep apnea because I was getting woken up several times a night being told, David, you're snoring, you need to roll over, or I get an elbow. So the problem wasn't, I didn't perceive the problem as mine. It was my wife's problem.
She needed to sleep. She needed to sleep.
I'm my wife's problem on a lot of different levels, but in that particular case, right? But so I mean, if your bed partner is saying, you're all over the place, or or there's sleep divorce, right? You're sleeping in separate rooms.
That's more common now, isn't it?
It's really common. I hear that all the time, and people don't like it, but they don't recognize it as an actual medical disorder.
And sometimes they won't
so.
talk to their provider about it. Like they'll mention it finally when they get to the sleep doctor or the sleep provider, but they don't always mention it to their primary care. Yeah. And then they come to us and they're like, well, if we haven't said anything about being sleep deprived, I'm like, why? This is something we need to talk about. I need to be aware of, and we could have identified something maybe earlier. Sleep.
Do more men have sleep disorders than women, or is it about 50-50? What do you see?
It depends on the disorder. Women are more likely to have insomnia disorders, and men are more likely to have sleep apnea disorders. And those things kind of come together as we get a little bit older. I mean, where women start to have more
with hormone issues.
With hormone issues. But many people, male or female, the sleep disorders are out there. It's just a matter of kind of ferreting out which of those they are. If it's 1 or 2 or 18 different sleep disorders, then we got to figure it out.
And that's another thing with talking about natural things to us. Women have the same amount of sleep apnea as men, or the same level, I guess, or what am I trying to say? Like percentage of women have sleep apnea once they go into menopause. Because of the decline in their hormones. So that's another natural supplement that
and the
if you're
hormonal changes
awakening,
in menopause also can impact sleep. That's
exactly
another whole discussion, I'm sure.
That's a natural supplement, not really a supplement, but it's a bioidentical replacement that is natural to the body that helps with sleep. And as women go in through perimenopause or into menopause, they frequently have insomnia. So replacing the hormone or treating them with hormones will help them. It also, if you have improved sleep, this goes back into our, sleep and circadian rhythm disorders, and how impactful sleep is if you're treating their insomnia and they're getting better sleep, then there is a reduction in their blood pressure. There's a reduction in stroke risk. Whereas we used to take women off of their hormone replacement years ago after the Women's Health Initiative because of the risk of stroke or cardiovascular disease. And now we're kind of changing our tune, switching that a little bit as we've learned more of the impact of sleep.
So we could do some of those things anyway just by improving their sleep.
Exactly.
So it could be a win-win.
Yeah. And then sleep apnea is common in women as their hormones decline. Because they're narrowing their airway, and that's where Dr. Book comes in from a surgical standpoint, or even just identifying like what the upper airway looks like in females. And maybe it's just, lack of skeletal muscle mass that we can work on to help reduce the snoring or treat the sleep apnea.
Dr. Book, can you talk about some of the surgical procedures you do and kind of how it helps?
Sure. Well, I typically with any medical problem, our options are to do nothing. We can use therapy, we can use medicine, or we can use surgery. And we try to go in that order. And so if you don't have a problem, if it ain't broke, don't fix it, right? And as we were kind of alluding to, a lot of the treatments we have for sleep disorders are therapy. Of some sort. That could be positional therapy for people who snore when they're on their back but not on their side, or it could be with changing the sleep hygiene environment that we're living in, making the environment better. And medications, I think, have a role in very specific sleep disorders. Unfortunately, sleep apnea is not one of those disorders, at least not yet. Research is out there.
I was going to say we'll see. Some clinical trials.
There's a couple clinical trials out there about a medication. I'm going to wait and see what happens.
We're not in that yet.
But the hallmark treatment for sleep obstructive sleep apnea is with positive pressure therapy. So that falls into that therapy category where folks have a device, a machine they wear that puts in basically an air stent that keeps the airway from collapsing when they're sleeping, which is what obstructive sleep apnea is. But for those who, and CPAP is great. People should not be afraid of CPAP. And I encourage you to talk to your primary care doctor, your sleep provider about positive pressure therapy options if you have obstructive sleep apnea. You'll be surprised at what the options are out there. It's different than your dad's sleep CPAP. Okay, but for folks who can't use CPAP, our goal with surgery in those individuals is to try to identify those areas in the upper airway where there might be sites of obstruction or restriction to airflow. So that's the hallmark of sleep apnea, obstructive sleep apnea, is that there's partial or complete collapse of the moldable, flexible airway that's up here. And if we can identify where those sites are, then there are things we can do to try to modify those areas. And sometimes that's improving nasal airflow for people who can't use CPAP because they don't breathe well through their nose. There are evolved techniques for people who have large tonsils, for example, or a lot of redundancy of the soft palate. There are techniques that we can do to try to modify and reconstruct those, where we might see the base of the tongue or the tongue falling back. There are techniques there that we might be able to help with that. And I mean, we're all seeing the commercials about the hypoglossal nerve stimulation. The brand name of that is Inspire. Basically, it's a pacemaker for the tongue that when used, it stimulates the tongue to move forward and get out of the way. And I think that's a really excellent treatment for some people with sleep apnea. It's not a one size fits all. And for those who are good candidates for it, we're seeing really great results with it. But it is a commitment to that device.
What about this device? What about this one? I had a friend who is about 10 years younger than I am, and because of sleep apnea, he had a stroke.
Yeah.
And his doctor sent him to a dentist to get something, a mouth guard, a mouthpiece that puts his jaw forward or something. How does that work?
So we refer to those as oral appliances or mandibular advancement devices. Right. And essentially it's a mouthpiece that just when you wear it at nighttime, it brings your jaw and your tongue, therefore, forward slightly in the mouth, so that it makes it less likely to fall back and obstruct the airway.
Oh,
yeah. Okay. And there certainly can be a role for oral appliances in treating, especially mild to moderate sleep apnea.
And you just titrate like as different settings on it, almost like orthodontia when you have the bands or as they tighten the braces. This is similar, but you wear it at night. They fit a mold and then it just kind of pulls the lower jaw forward, and it has different settings. And the dentist will do sleep studies on them at home and then refer them back to sleep medicine providers to do the kind of final diagnostic test to confirm that the mandibular device or oral appliance therapy is working.
Okay.
And some insurances pay for it. Some do
better.
not. It's getting better. CPAP has been our tried and true, or positive airway pressure has been our tried and true for a long time, that is covered by insurance. And again, I'm with you.
I'm a proud CPAP user. I mean, I even though I'm somebody who my job is to surgically treat sleep apnea for those who can't tolerate it, I tell everybody I wear it every night and I love it. And so
you feel better.
I feel great.
Okay.
Yeah. You wake up refreshed, and that's the thing. Like nobody's opposed to taking a pill at night or during the day. So
pills are easy.
To me, I'm like, why is it a struggle to wear? And I don't wear a CPAP every night, but I have tried on every mask in the office, and I've done the variety of different pressures so that I can just be a guinea pig on myself. And when patients come in to me and they're like, this mask, this pressure is so annoying, or this doesn't work right, or that doesn't work right. And there's millions of not millions, hundreds of masks out there now.
But some people score, so I'm going to change that. There's a lot.
Yeah, there's a lot of different masks out there now that are comfortable, and what mask works for me may not work for you.
Do they have a Denver Broncos mask, or for me a Chiefs mask, or
don't go there. Really?
Why?
Okay, all right. I'm from Kansas. So you're a Nebraska girl. You should.
I know,
you should
and
be a Chiefs fan.
I don't like NFL.
Okay, all right. Well, never mind.
All right, before you guys go, I get you out of here, I've got to ask a couple questions that a little bit, tell me if they're myths or not. For example, one time I had heard or read that during REM sleep, rapid eye movement, that basically from the neck down, you are paralyzed. And the only thing that's really moving is your eyes, which move horizontally, but that's pretty much it. I mean, you are in a paralyzed state. Is that really true?
That is true. During rapid eye movement sleep, that is a time of sleep where we do a lot of our dreaming activity. And as we should all be aware, I mean, dreams are very active. We're doing things. And so in order for us not to act out those dreams, our brain turns off our muscle control below, other than our heart and our lungs, our voluntary muscle control, so that when we're having our dreams, we're not acting them out. We're not punching people. We're not trying to run. We're not,
We don't have parasomnias.
Activity. And that's one of the disorders of REM sleep disorders or parasomnias, which are a lot of times in the non-REM sleep, but still are associated with movements. So that is not a myth. That's true.
Yeah.
We are essentially paralyzed from the neck down. Other than
they kind of self-protect us, right? I mean, so we don't do crazy stuff.
And the people laying next to us.
Yeah,
Yeah.
exactly.
Yeah, you don't want to. It's hard to explain a black eye. I hate to say it.
Yeah, true. What about this one where I had read a study once? I don't remember if it was Russell Foster or if it was Matthew that discussed his book. But anyway, men who average 5 hours or less of sleep per night have, number one, smaller testicles. And number two, they age themselves in terms of virility, strength, and stamina by about 10 years. Is that true?
This one's all yours.
This is true.
I don't have testicles.
This is true.
Thanks, Joe.
This is true on both counts. So what we talked about circadian rhythms, and one of the circadian rhythms that we see is testosterone excretion that occurs, and it peaks during the night hours when we're asleep. So if we're reducing the amount of sleep time that we're getting poor junk sleep, our testosterone levels don't rise as high. So testosterone is one of the hormones that is produced in our sexual glands, and if we're not producing a lot of testosterone, then our nuggets start to shrink up a little bit.
Our nuggets.
So
you know what nuggets are, Jodi?
I call them testicles. So I try to use the proper term.
Okay, so yes, our testicles will shrink in size. So if you're out there on the golf course with a guy who's he's bragging about how he can work on only 2 hours of sleep every night, I'm not saying you need to compare, but just let him know that your cojones are bigger.
I got bigger gonads than he does.
Yes, you do. Yeah, you've.
Okay.
You've got more brass. Okay, all right.
It's good to know. These are things that men want to know.
Well, and it's absolutely true. And we're joking around a little bit, but it's absolutely true that virility, that testosterone levels, that libido, all of those things diminish with poor sleep. So if you want to be that Casanova that you've always dreamed yourself to be, for God's sakes, get 8 hours of sleep.
I'm gonna get at least 10.
Okay, right now. Well,
that's not
again,
good.
There's only
Too
so
much
far we can go. Okay, all right.
It's like, 7 to 9.
7 to 9
so
hours. Yeah,
shoot for 8.
7 to 9.
But one thing I've got to ask you is that even with guys with erectile dysfunction, don't they still get wood during REM?
Yeah, they sure can. Absolutely. So again, sometimes there's more to it physiologically than that. I don't know. Jodi and I were talking earlier
about wood.
I love it that I'm still like with teenage boys that you guys call it wood. It's like we can just say erection.
Well, but
you guys still find it humorous.
Yes, we do.
I know.
Once a boy, always a boy.
Exactly.
But is that something that if that stops being the case, or if we're starting to see problems with that, is that something we need to be worried about?
Yeah, I think that's one of the reasons if you go to your primary care and you're asking about that, that's the first indication to do a sleep study too, because not only are you checking testosterone levels, because we know that testosterone is made at nighttime and it elevates at nighttime, and if we're getting good sleep, more than 5 hours of sleep, we know that we should have pretty steady state testosterone levels. Check those levels, but also that's a time to really talk about sleep, because if you're not having that morning erection anymore and you're more fatigued, to me, that's the first time that you go to your doctor and they refer you to sleep, or they do a sleep study to identify, is it something else that's driving that, that's contributing to the loss of erection in the morning.
These are things the guys want to know, Jodi.
Yeah,
we talk about this.
Absolutely.
Stuff.
And, you know, so anyway.
Not a
And-
polite
and wives
conversation
talk
like
about
this,
it,
but
too.
yeah.
You know what,
I
Jodi?
mean, and some may say like, maybe we don't want him to go to the doctor.
I've got to hand it to you, Jodi. I mean, we've talked about a lot of different things, and you're the only female here, and we've got to put you on the spot.
I know.
I do appreciate it. But thank you, guys. I want to just kind of wrap it up and say, Dr. Book, thank you. It's been amazing meeting you, amazing learning from you about sleep disorders, and all that we can do. And Jodi, as usual, you're phenomenal. I appreciate you so much.
Brad.
And, you know, obviously you do a great job, and I enjoy the podcast with you. Do remember to like, comment, and subscribe if you'd like to. We're going to have more of these type of formats in the future. We certainly hope you enjoyed it, and we wish you the best, and sleep well. Thank you.
Thank you.
Good night.